Dr. King.
So as Megan indicated, my laboratory focuses on exploring biological mechanisms underlying bone and joint pain. And today I'm really going to be focusing on joint pain, explaining a little bit about what we're doing and what we're examining using a rat model of osteoarthritis. Because this is a CME, I want to emphasize that I have no financial conflicts of interest to disclose. My overview, what I want to do is just state or share what key features of osteoarthritis are in adults, go over some current limitations and treatments, and emphasize that this is why we need a better understanding of the biological mechanisms underlying osteoarthritis-induced pain. I'm going to describe our animal model and how we get at these questions, and talk a little bit about our data examining sex differences, differences or attempts to explore differences between the site of the osteoarthritis. We've developed models both in a load-bearing joint, the knee, as well as a non-load-bearing joint, the TMJ. And finally, I'll go over our experiments assessing what the impact of exercise is on osteoarthritis pain, and we've also done some experiments on pathology in the joint and specifically the bones of the knee. Okay, so arthritis is really the most common joint pain, the common source of joint pain, and it is characterized, of course, by pain, but also stiffness and swelling. It can limit the function of the joints. And it is a leading cause of pain and disability, both in the United States, and there are many reports actually that this is a leading cause of disability worldwide. So a couple of things to really emphasize is that about 22% of adults were reporting arthritis-associated pain. And in 2014, approximately 1/4 of those adults were reporting severe pain. So this isn't just mild to moderate pain. The other really key aspect of this is that these numbers are rising, okay? And so there was a significant increase between 2002 and 2014 in the number of adults reporting severe joint pain. And this is actually projected to continue to rise. Oh dear. Okay, I won't stand on that side. So osteoarthritis is actually the most common form of arthritis. There's, of course, other forms. There's juvenile arthritis, rheumatoid arthritis, which I know many of the students have touched upon. But osteoarthritis is by far the most common. And it tends to affect different joints, although in an individual patient, it tends to be unilateral and oftentimes one joint. Things like load-bearing joints like the knee or the hip are often associated with the knee being the most common site. But you can also have osteoarthritis develop in non-load-bearing joints, including things like the hand and, although it's not on this particular image, the jaw. Okay. Now, women are more likely to have or be diagnosed with osteoarthritis, and they report more severe osteoarthritis. And this is important as people, at least, especially in the pain literature, but in general, are starting to think about exploring sex differences across a variety of disease states, pain being, of course, one of many. Risk factors for development of osteoarthritis include things like obesity and being overweight, increased age, so the highest prevalence that are in adults over 65 years of age, although I will put a caveat in there, that age is going down. And it's thought that part of the reason might be due to the obesity and the sedentary lifestyles that we're leading. Joint injury is certainly a predisposing factor, but it is not always what is underlying development of osteoarthritis. And of course, repetitive use of joints at work leads to development of osteoarthritis. I will point out that another thing that's happening is that we are working for longer and longer and at older and older ages. In fact, Senator Collins just had a panel on this. As I said, the prevalence of arthritis is increasing. A lot of this is underlined by prevalence of osteoarthritis increasing. And this, again, is thought to be due to an aging population combined with the obesity epidemic. And so more people living longer and basically being fatter, we're getting more osteoarthritis, and we are actually seeing it at younger ages. So osteoarthritis can be diagnosed in a couple of different forms. One form is radiographic osteoarthritis, and even today, this is the most common way to diagnose osteoarthritis within the clinical setting. And so you see things like narrowing of the joint space. Well, I'm going to turn that to red. So that you can see the reduced cartilage. You also get development of things like osteophytes and sclerosis of the subchondral bone, so a thickening. And these are things that are readily apparent in a radiograph. Now, the other side of the coin is symptomatic OA, okay? And these are actually the symptoms that the patients report. So pain that worsens with joint use, and in many patients can be alleviated with joint rest, muscle spasms and contractions of the tendons, and a grating sensation that is heard when the joint is in use, the stiffness and other sequelae. Now, one important thing about this is that the radiograph pathology does not necessarily correspond to the symptoms being reported. And so many times, patients might have very little evidence of pathology on the radiograph and yet be reporting high degrees of pain. In contrast, I've heard from several physicians saying that they took a radiograph of the knee, saw a robust signs of osteoarthritis, and yet the patient had very minimal pain or signs of pain. And so this really highlights to me our lack of understanding of the basic biological mechanisms that are underlying osteoarthritis, and certainly OA-associated pain, and one of the reasons why we need more research. So I've already mentioned how OA is marked by cartilage loss and subchondral bone sclerosis. But as we're getting better and better imaging techniques, we're discovering more and more things about osteoarthritis. And so things like MRI and micro-CT are highlighting things like development of bone lesions, synovitis, and other aspects of bone remodeling and changes in the joints that might be better associated with pain than what we can just get from a radiograph. There are also subsets of patients where there's been evidence of bone resorption or trabecular bone loss, further compromising the joint and the bone. So there are currently no treatments for the cartilage loss and the bone changes, and most of the treatments focus on pain relief. And so let's go over kind of what the patients experience as far as pain. So osteoarthritis can be described across a number of stages. Early osteoarthritis is predictable sharp pain, and it is usually triggered by a high impact sport, for example, skiing. Has relatively little other impact. Mid-stage osteoarthritis is actually probably the osteoarthritis you commonly think of when you think of it. And so this is pain, it's still predictable, and it's usually associated with daily activities, maybe gardening or climbing stairs. Obviously, it begins to affect daily activities because if it hurts when you climb stairs, you're not going to want to climb stairs. Finally, some patients develop what's called advanced osteoarthritis, and this is associated with the development of a constant dull, aching pain that's persistently there. So resting the joint doesn't get rid of the pain as it does with the other stages. This pain tends to be non-responsive to current therapies such as NSAIDs, okay? So it seems not to be mainly driven by inflammation, and evidence is accumulating it might have a neuropathic pain component, okay? There's significant avoidance of activities by these patients, and they start to become more and more isolated, which anyone with psychology background knows that's not optimal, and won't help with any aspect of that patient's life. So what I thought I'd do is do a very sky-high brief overview of potential mechanisms mediating pain and a rough diagram of the pain pathway. So when we have the joint pathology develop, there are several different contributors that would drive the nociceptors or the pain fibers within the joint. And these include things like inflammatory mediators. Even though osteoarthritis is described as a non-inflammatory arthritis, that's because it's relative to things like rheumatoid arthritis, which has a tremendous amount of inflammation. Osteoarthritis still has pro-inflammatory mediators associated with it. You have mechanical factors, you have diminished cartilage, you have bone remodeling, bone deformity, and in some patients there are signs of nerve damage, and many preclinical models are really following up on a potential neuropathic pain component to advanced osteoarthritis. These factors drive nociceptors, which I'm indicating here, which project to the spinal cord. There we have a synapse. The second order neuron then crosses the spinal cord, goes up to the brain, and I'm leaving it nebulous there. It doesn't just go to where there's not a pain center or pain nucleus in the brain. It's a very complicated network, and it is processed at several different areas within the brain, and that's where it's perceived. In the context of a chronic injury or a chronic pain state, a couple of things can happen. You can have development of what's called peripheral sensitization. And this is where the qualities of the pain fibers change so that, for example, they can be activated at a lower threshold, or they send an amplified signal to the spinal cord. And these are thought to be associated with clinical correlates of hyperalgesia, where you have an enhanced pain response to a normally noxious stimulus, or allodynia, in which a pain response is felt or reported to a normally non-painful stimulus, such as climbing stairs, for example. You can also have amplification of the signal within the spinal cord going to the brain, and this is associated with what's called central sensitization. And one other aspect of the pain pathway that's really important, especially in the context of exercise, is that pain signals can be modulated from descending systems from the brain. And we can have descending facilitation, which enhances the pain, and you can have descending inhibition, which actually dampens the pain. And these are thought to be a balance. Okay? Now, this is a lot of information, right? And you're thinking, well, we have a lot of potential targets. But most of the treatments for osteoarthritis are really focusing on key peripheral components, such as inflammatory mediators, mechanical factors stabilizing the joint, for example. Recently, well, I say recently, but it was in 2010. I'm just going to keep saying recently, belie my age. Duloxetine was approved by the FDA for treatment of osteoarthritis. And the deal here is that duloxetine is a serotonin norepinephrine reuptake inhibitor, typically used as an antidepressant, but it's also implicated for patients with neuropathic pain. And so patients that might be resistant to things like NSAIDs might be responsive to duloxetine. But it should be noted that all of these treatments have side effects. We might be able to do better. And we need to better understand the pathology and how that drives the pain state in order to develop these alternative therapeutics. In order to do that, many of us turn to animal models. And in my laboratory, we use a rat model of osteoarthritis. The model consists of injection of a compound, monosodium iota acetate, directly into the interarticular space of the knee joint. And I have adopted this. This was not developed in my lab. This has been well characterized. And what happens is you get, if you look at these images here, that was good drawing. If you focus on the purple, you can see a concentration-dependent diminishment, and that is cartilage, okay? And so the injection of this compound causes cartilage reduction consistent with osteoarthritis. And you can see this also in radiographs, on this one hopefully up there, where you can definitely see a narrowing of the joint space. And if you have a trained eye, you can start seeing development of osteophytes and other signs of radiographic osteoarthritis. When we took the bones to MMCRI, they were able to do micro-CT analysis of the bones. And what we can see is, like some of those reports, we clearly get trabecular bone loss in the metaphysis of the tibia in this model. And so we have a lot of corresponding pathology that looks very similar to the clinical scenario. We also, of course, look at pain behaviors. That's really what my lab is very interested in. And so one of these pain behaviors is looking at joint use and function. And we do this by analyzing how much weight the animal puts on each of its hind limbs, okay? And so you might want to think about this. If your knee really hurts, you're going to shift your weight away from it. And so that's exactly what the rats do. And so when we put them on this device, they're standing, so each platform measures each independent leg. And over time, or by day 14 post-injection, they're standing so they're not putting weight or as much weight on the MIA-treated hind limb. Now, as I said earlier, we're very interested in examining what's called this advanced osteoarthritis, which is characterized by development of this persistent background ongoing pain that really doesn't go away. And so we use a behavioral paradigm in which we look at this by measuring condition-placed preference to pain relief. So the idea is that pain relief is actually rewarding, especially if you have a chronic pain state. If that pain goes away, you feel great. And so if we pair that with a distinctive context, then the animal should spend more time in that context. And that's exactly what we find. And in the case of the MIA, what we find is that if we subtract the preconditioning value from post-conditioning value, and they like that chamber, they spend more time, then you should see a positive value. And this high concentration of MIA produced the ongoing pain state. So now we have a concentration range that we can really assess this population of advanced osteoarthritis and start to get an idea of what's going on. Now, all of that was characterized in male rats. So one of the things that we've been doing more recently in the laboratory is adopting these models or adapting these models to female rats. And so remember at the beginning I said that women tend to be more predisposed to diagnosis of this, and they report more severe pain. So one of the things that we did was we looked at different concentrations of monosodium iota acetate injections. And so we have a couple concentrations here, 1 milligram in 60 microliters versus 4.8. So it's a roughly 5-fold difference. And you can see the purple bars and the blue bars look about the same. So there doesn't seem to be any difference in the amount of weight they're shifting away from the injected knee joint. However, if you look at our development of ongoing pain, I think the key here is that if you look here, this 1 milligram dose was sufficient to induce condition-placed preference. In other words, it took a 5-fold lower dose to induce ongoing pain in females compared to their male cohort. Okay. So the other model we wanted to set up is osteoarthritis in a non-load-bearing joint. And here we looked at the temporal mandibular joint, TMJ. What we're doing is we're injecting the MIA, which apparently wasn't on here, directly into the TMJ. Had a very talented, at that time, undergraduate who was interested in pre-dental, figured out how to do this, and really led the development of this model. So injected into here, we see development of joint pathology, we see cartilage loss, and we see bone remodeling that is consistent with reports of osteoarthritis. Now, we can't, of course, do weight asymmetry in these animals. So what we did was we looked at development of tactile hypersensitivity. And we did this by probing them with von Frey filaments. Von Frey filaments are just basically calibrated filaments that takes a different amount of force to bend. And so you bend them at a site, and you look for withdrawal behaviors from the animal. And basically what we found was that within 1 day of injection, we are starting to see development of tactile hypersensitivity at the ipsilateral side, so on the same side where the injection occurred. Now, one thing that we found very interesting is that over time, we saw development of hypersensitivity in the midline, so the infraorbital site, which is right here, as well as on the contralateral site. We also actually saw it develop in the forepaws and then the hindpaws. And so what we're thinking here is that we're probably seeing development of central sensitization, a hypothesis that we'd like to examine further down the line. Again, we looked at development of ongoing pain using that condition-place preference to pain relief. This time we were inducing pain relief by systemic administration of duloxetine, the drug I mentioned earlier. And what we saw is that the duloxetine certainly induces condition-place preference. Again, this is characterization in males, so we switched over to females. Being guided from our data with the knee joint, we used a 5-fold lower dose. And this is actually supposed to be a blue bar again, but anyway, what you can see is that the 5-fold lower dose induced condition-place preference in the females. So again, we have a model of advanced osteoarthritis, but this time it's in the jaw. Okay, so we have a rat model of advanced osteoarthritis pain. It's showing sex differences in that a 5-fold lower concentration of MIA is required to induce this in the females. We're looking at the pathology and the bone remodeling as we speak, so I don't have that data for you, I'm sorry. But certainly there's implications for big-time sex differences. And we've developed a nice osteoarthritis model in a non-weight-bearing joint. And so what we wanted to do was go ahead and use these to examine the potential effects of exercise. So exercise is the #1 recommended non-pharmacological treatment for patients with osteoarthritis pain. And there's evidence in the clinical setting that exercise can be effective, but there are many questions remaining. What exercise, what intensity? Is it aerobic or is it strengthening? Preclinical studies have started trying to examine some of these questions. Many of them have been in other models, such as musculoskeletal pain of the rat thigh, for example, or in neuropathies, but no one had really done it with a joint injury model until we started examining it. And of course, we'd like to examine this because it can increase our understanding of the biology underlying benefits of exercise relation to pain, increase our understanding of the pathology underlying joint pain, and what we discover about the beneficial effects of exercise might be applied to the joint pathology itself, and we might be able to find alternative therapeutics with fewer side effects. But of course, if exercise works, we want to build on that as well. So what we did was we took our rats and we injected them with MIA, and then we waited 10 days. We waited 10 days because we wanted to see if it would actually reverse pain associated with development of osteoarthritis. We're not doing a prevention model at this point. The exercise was 30-minute sessions, 4 days a week. The 5th day of each week, we did behavioral analysis of the different pain states in the absence of any exercise. So we don't want any acute exercise-induced modulation of pain here. The rats and experimenters were allowed to rest over the weekend, and then we started again the following Monday. And what we found was that this paradigm nicely alleviated the weight asymmetry observed. We took a cohort of animals at day 35, a time frame where we really saw a nice difference between exercise and sedentary animals, and we looked at ongoing pain. And what we found was that our peripheral nerve block, joint lidocaine, we're using a volume that goes beyond the articular space. So lidocaine induced condition-place preference, indicating it blocks the ongoing pain that's observed in the sedentary animal. But there's no CPP in the exercise animals, indicating that the exercise has alleviated the ongoing pain in those animals. Okay. Now, as we were doing this, we also took radiographs because we didn't know whether the exercise would have any beneficial or adverse effects on the joint. And so basically, what I can tell you is the radiographs did not show any apparent evidence for benefit or worsening of the radiograph pathology. But I wasn't satisfied, and I wanted pretty pictures. So we took the samples to MMCRI, and we had them do micro-CT analyses. Now, the benefit of micro-CT analysis, besides the pretty pictures, is that you get a much higher resolution idea of what's going on with the bone. And what we found was quite striking. I think you guys could probably just see it by eye, but you can see the amount of trabecular bone loss in the sedentary animals, and you can see that this is ameliorated by the exercise. So the exercise has protective effects against bone loss observed in this model. Okay. So although the protection against bone loss might be one potential mechanism by which we're alleviating the pain, there was another mechanism that's implicated in the pain literature. And this is recruitment of descending pain modulatory systems. And so just to step back and give you some background on this, clinical studies as well as preclinical studies indicate that there are signs of increased pain sensitization in osteoarthritis patients. And the idea is that there's a shift in the balance between the descending pain modulatory pathways. So you have enhanced facilitation and diminished inhibition, okay? And so when you have this, then you're going to have an enhanced pain state or chronic pain. We have demonstrated that we have a switch to central sensitization, and that there's a role for these descending pain facilitatory pathways in our animal model as well. And so what we did was we blocked activity in a key brain region implicated in descending pain modulation, the rostroventral medial medulla, or RVM for short. And so what we did was we just inject lidocaine, and that shuts down neural activity in that region. When we did this, what we found was we produced condition-place preference in our MIA-treated animals, indicating that the blockade of these descending pain facilitatory pathways is sufficient to block ongoing pain in these animals. So why am I going into this? Well, one of the things that we were thinking is that maybe a way that exercise could block pain is that it could maybe shift the balance of these descending pain modulatory systems away from facilitation and towards inhibition. And one key component of descending inhibition has been shown to be endogenous opioids. So we had the tools readily accessible to test this hypothesis. And we did this by using an opioid antagonist called naloxone. And so when we injected naloxone into the animals, what we found was that exercised animals, remember, we have alleviated the weight asymmetry. What we do is we give them naloxone, test them 30 minutes later, you have unmasked this weight asymmetry. Okay? So what this implies to me is that the underlying pain state is there. It's just being masked by the descending pain inhibitory systems. Okay? And so what I've been trying to show you is that forced exercise on a treadmill across 4 weeks reversed joint pain. And it helped with the MIA-induced bone degradation. But the diminished bone loss did not explain the pain relief. Okay? So the pain is still there. And I suspect it's because we were using a reversal paradigm and not a prevention paradigm. Yet another hypothesis to explore. But rather, the forced exercise seemed to be blocking the pain by recruitment of our endogenous opioids and activation of the descending pain inhibitory pathways. Okay. So this is all true in male rats. Of course, we wanted to ask the obvious question, what about female rats? It is conceivable that exercise is not as effective or not effective in female rats. They're more susceptible to pain. We see a lower concentration required to induce ongoing pain. And so basically we took our same paradigm, so nothing's changed so far, and we looked at whether this exercise paradigm blocked weight asymmetry in our female animals. And what you can see is that the exercise does seem to protect against the weight asymmetry in the female rats. And we also found that we block the ongoing pain in the female rats. So the exercise animals do not show CPP. Again, we're doing systemic duloxetine, whereas the sedentary animals do. Now, I should mention that this is preliminary data. You'll notice that big error bar on the thing. This is underpowered, and we're currently trying to get the additional animals. But I'm very confident that we'll see a replication of this pattern. We did a similar thing with non-load-bearing joint. So similarly, we did our exercise paradigm, this time again in female animals that had received injection of MIA into the temporal mandibular joint. Now, we started doing every Friday testing of tactile hypersensitivity, and what we discovered is that rats are really, really smart. So if you see a stimulus that causes pain approach your face, you're probably going to avoid it, right? Well, so will a rat. And so the rats quickly learned to avoid the approach of the Montfray filament, and we couldn't continue testing after 21 days. However, we could do our condition-place preference. And so we tested at the same time point that we had been routinely seeing pain relief in the knee joint, and what we found was an attenuation, but not a full blockade. So we continued to exercise the animals. And what we found was that if we exercise them across 9 weeks, now we do see blockade of the ongoing pain. And so what's interesting is that it does seem to take a lot longer to produce pain relief through exercise in the TMJ osteoarthritis compared to the knee joint. And so we think that this is site-dependent and not a sex-dependent effect, because female rats with knee joint osteoarthritis show pain relief within the 4-week exercise paradigm, but with the TMJ required 9 weeks. But we will verify that by testing a male cohort with the TMJ on the exercise. Okay. So, forced exercise alleviates OA-induced knee joint pain in about 4 weeks in males and females. But in the TMJ OA, it took a lot longer. It took about 9 weeks in order to alleviate the ongoing pain. Okay. So at the beginning, one of the things that I said was that exercise is top recommended non-pharmacological therapy for osteoarthritis patients. But what are we doing with our rats? We're forcing them to exercise on a treadmill with a shocker in the back even, okay? Now they learn rapidly. They're not shocked every week or anything. They're actually only shocked the first day. But clearly there is a differential between saying, go out and exercise, and I'm going to put you on this thing and you better, run. And so we wanted to see what about voluntary exercise. And so I was able to collaborate with my colleague Glenn Stevenson here, who has running wheels for rats. And what we did was we trained the rats to run. And these group assignments are what they would be assigned to. Nobody has any treatments yet in this particular graph. And what we're doing is we're just putting them on the running wheel. Well, we're putting them in cages with access to running wheels overnight, and we're just seeing how much they run. Turns out that some rats really like to run, and some rats not so much, kind of like us. And so what we did was, once they got to a fairly stable running rate, we injected them with MIA. Now again, we waited 2 weeks to give them access to the running wheels again. And so perhaps not surprisingly, both the saline-treated group and the MIA-treated group showed a diminished distance in running that first week afterwards. But the saline animals recovered to previous levels, but whereas the MIA animals maintained this lower rate of running for the remainder of the study. Now, one of the things that we wanted to do is say, well, can we even compare this? What about the quote-unquote intensity? And I'm using that term lightly here, loosely here. Are they running at the same intensity as we were using on the treadmills? And so we took the peak 30 minutes of their running behavior and we calculated the speed at which they were running. And basically, first of all, you can see that these guys are running 30 meters per minute. They're running at a pretty rapid rate. After the MIA, they're going down, and this dotted line is very interesting because that dotted line is 16 meters per minute. Turns out that's what we had the treadmills running at. So the animals, without any treadmill experience, kind of naturally went down to about the same rate that we were training them on the treadmills. So we know at least that they can achieve that rate of running, and they can achieve it for 30 minutes. I wanted to do this to say, well, are we even comparing anything close to what we're doing on the treadmills in relation to pain behaviors? And so, again, like before, we're looking at weight asymmetry every Friday in the absence of exercise. And basically what we're finding is that it doesn't help. So when they were given free rein to run voluntarily, it didn't seem to alter their weight asymmetry. This is in contrast, remember, to the treadmill. After the 4 weeks, we went ahead and tested for the ongoing pain and found something as a surprise. What we found was that the low runners still had pain. In other words, they're showing condition-place preference to pain relief. In contrast, the high runners failed to show condition-place preference to pain relief, indicating there's no pain to relieve. And so it seems that there is a modality-specific effect of the voluntary exercise, something that we found very interesting. And so we're following up with the bone remodeling question as we speak. So, conclusions: forced exercise blocks weight asymmetry and ongoing pain. Voluntary exercise blocks ongoing pain, but failed to block weight asymmetry, something that is kind of surprising, and there's a lot of questions associated with that. Other questions that remain, of course, there's many, but what are the effects of age, as well as further elucidation of what are the effects of sex on both pain and exercise? And what about prevention? So if we do a prevention running paradigm, can we prevent bone remodeling, other immune factors that might drive development of neuropathic pain and that advanced osteoarthritis? And so with that, obviously, we work with a lot of different people to get this beautiful data. The histology was done by our very talented Peter Cardona at the H&E Corps. Glenn Stevenson is my wonderful colleague. We're working together on the voluntary exercise aspects. We did micro-CT in collaboration with MMCRI. Lucy Lau is the core director, and Terry Henderson is the magician who does the bone imaging and analysis. And I have a very talented and large lab. I want to specifically acknowledge my lab manager, Sebastian Sanagist, who really drove development of the TMJOA model. A lot of our funding for some of these came from Peter Morgaine fellowships, and I had very talented medical students, Joe Heath, Elizabeth Kim, who's here, and Alex Chassie, all had data that was in here. And then I have had a host of undergraduate students that have contributed to these and other projects within my lab over the years. With that, I'd like to take any questions.
Thank you for that. Because OA involves wearing down cartilage, what is the long-term effect of exercise on the cartilage?
Right, so people have reported just overall joint pathology, and most of the reports have reported no overt effects on cartilage itself. On bone deformity, there's really not much. But there are reports out there that it delays the requirement for surgery for osteoarthritis. So those are, the main findings.
Yeah, so it's really interesting. And you spent a lot of time talking about bone and peripheral mechanisms. But as a psychologist, I noticed that 2 of your effective treatments was an antidepressant and exercise, which is nature's antidepressant. And you can reverse that effect using naloxone, which also can induce dysphoria, certainly in people with lots of endogenous endorphins around. And so I'm wondering if you could talk about the role that mood or affect might be playing in some of this.
Thank you. Fantastic question. So one of the points that I was trying to make there is that just simply focusing on the peripheral mechanisms is clearly not sufficient. And so we need to broaden our scope. The antidepressant, the effects of the antidepressants on pain seem to be at doses that are different from antidepressant effects itself. However, having said that, the comorbidity of depression and anxiety with chronic pain is huge. And we know that there's a huge cycle between these comorbidities, sleep cycle, and pain. That's also why I mentioned the social isolation, which is another huge factor. And so those are factors that are certainly outside my wheelhouse working in rats. But what I can tell you is that the social factor, things like mindful meditation and other top-down potential beneficial treatments seem to be recruiting this opioid system. And notice I didn't mention the cannabinoid system. Certainly it is involved in inhibition of pain, and certainly there are central mechanisms there as well. I just didn't have time, nor did I have data on that system. But that is not an irrelevant system at all and should be studied much more. Yeah. Dr. May and then Dr. Williams.
Do you have any plans to look at overectomized females, and would you expect them to look more like males, or is there some other factor involved?
There is some other factor involved. So overectomized females have a predisposition to develop osteoporosis. And so in that case, you would be combining the osteoarthritis with osteoporosis. We may be seeing a little bit with the bone loss here. And so I think that that's just a whole other study. I'm interested in doing that because osteoporosis is also affiliated with pain. And so I think there's a lot of interesting questions there. And whether exercise would protect against that would be a huge benefit to know. Dr. Williams.
Yeah, in human therapy right now for osteoarthritis, there's some cutting-edge treatments out there that are controversial, sort of. Stem cell is one of those. Prolotherapy, there's some viscous things that go into the joint, Synvisc, and you flex, and you're probably aware of some of those. Can you address the stem cell? Where is that actually replacing the cartilage? I have a neighbor who had that done and recently, and it's working real well for her. Where's the site? Is it trying to replace the cartilage there?
My understanding is yes, but that's outside my realm of knowledge, so I don't want to speculate any further. I know it's controversial, especially in relation to effectiveness as well as potential side effects. So people are being cautious with that. The other up-and-coming therapy that's probably closer than stem cells is anti-NGF, anti-nerve growth factor. And that's actually been in clinical trials. It got to a late-stage clinical trial and then got pulled because of side effects, but has been reapproved to go back into clinical trials, and it has been found to be very beneficial, actually. So there's a lot of hope for that. Dr. Davidoff.
Yeah, that was a great talk, and a sign of a great talk is every time I have a question, you eventually answer it, so that's really good. Either that or I'm getting slower in my old age.
Doubt that.
Or both. So you showed us some micro CT scans where the effects of exercise improved
Bone loss.
bone amounts,
Right.
And I think I got that most of your protocols are reversal, so you induce and then so it comes back. That's astounding.
It is
was that?
astounding, but I'd be cautious with that interpretation, and here's why. What we're doing, we only took the micro CT bones at that late stage, and so since we started after, presumably some bone loss might have started. We don't know if it's just a protection, a stabilization, or an actual recovery. My gut feeling is it's probably a stabilization, but that's a question we have to address.
That's cool. And the other was the TMJ model. If I read the slide right or heard you right, after 3 days, there was a systemic hypersensitivity in some of your
Within
animals?
3 days, there's definitely an ipsilateral. Sure. Sebastian would be very happy to take this question.
After 3 days, it shows that it goes to the infraorbital site, but then after it goes to contralateral by day 7, and then by day 14, everything's hypersensitized.
So foot pads and everything, and wouldn't
Right.
that affect how they exercised?
Well, so that would be global, and so I would think, well, we don't know, is short. We haven't done these guys on the running wheel. That's definitely something we want to work with Glenn with. one of the real reasons, other than inherent interest in TMJOA, was what is the potential impact of exercise on non-weight-bearing joints and pain in non-weight-bearing joints on exercise. And so we can do that most effectively using the wheel running in a voluntary exercise type scenario. So it's an excellent question, and we don't know yet.
So just one last noodly thing. In the cardiac world, any type of intervention, they were seeing, especially in rodents, they were seeing that the females, no matter what the interventions were not presenting with whatever phenotype, heart failure, whatever. And what we found in my lab is that it actually just took longer for the females to present with the phenotype. Now that's a whole cardiac thing. That may be different than the osteoporosis. But I noticed one of your interventions had to go out 9 weeks.
Right, and what was interesting, because that actually was my hypothesis going into the exercise on sex effects. However, the sex variable did not matter in the knee osteoarthritis. So the exercise was equally effective across 4 weeks in males and females. What seemed to be a critical factor in the time was the site, so jaw versus knee joint. And I think that brings up a whole host of very interesting questions. Dr. Ganter?
Professor King, excellent talk as usual.
Thank you.
I have a question. Can I sit and talk?
Hold that towards you.
Okay, thank you. I have a question that follows up on the issue of the TMJ model. And I wonder to what extent you've considered that in this model eating is a form of exercise?
So no, you may not answer that. So we did, and in fact, one of the first things that we analyzed was eating behavior. And we were pretty excited about that because we wanted a joint use measure, kind of like we do in the knee joint. And so what we found briefly is a transient change in their eating behavior. So it impacted their eating behavior maybe across the first week, but then it recovered. And so one really critical aspect of this and how it differs from other models in which they look at eating behaviors is that we were very careful to try and closely relate to what's seen in the clinic. And so we did a unilateral injection, not bilateral injection. And so what we suspect is that they're adapting their eating so that it's less stressful on that jaw. And so we're going to have to get good video cameras and see if we can figure that out. So yes, exactly.
They don't lose weight.
They did not lose weight. And overall, time spent eating overnight was the same. It's the pattern of how. So basically, instead of eating like so many meals, what happened was they became snackers. And they ate for less time per meal, but more meals across the night. And so their weight did not change. We were very careful, knowing some psychologists, and how we measured eating behavior. And what we did was we kept them in their home cage and we just videotaped them, which means that they were grouped housed. And so we didn't weigh the food. We only weighed the animals. I'm sorry, I see lots of hands. Let me go to a student, and then I think Ling was next. Oh, there's 2 students. Sorry, Ling, you're gonna have to wait. First you.
Hi, Dr. King. This is a question that goes off of Dr. Davidoff's question about the expansion of the trabecular bone, or at least stabilization of that bone with exercise. And I was wondering if you could speak to the proposed mechanism of how that's accomplished, or if you followed that up at all.
So I'm actually really excited about that question, and that's one of the things that I'm kind of playing around with for my next grant. So it turns out that exercise has good effects on your immune system so that it shifts the balance from kind of a pro-inflammatory state to a more of a protective state where you see more anti-inflammatory cytokines like IL-10, for example. And so what these pro-inflammatory cytokines not only precipitate pain, but they can also facilitate bone resorption. Okay, so they drive osteoclast. And so what I think could be happening is that the exercise through that mechanism is dampening the bone resorption. And so that's why I'm very excited to try it in a prevention paradigm. This is a hypothesis. There's literature out there supporting that, but it's not been shown yet. That's something I'd like to expand on. Yes.
So I was actually wondering about, in addition to measuring voluntary exercise, if you had looked at sort of general ambulation. So a lot of tying to clinical research in humans would be assessing not just their ability to participate in voluntary exercise, but also in their sort of level of activities of daily living, as ADLs is sometimes what they're referred to.
Okay.
So measuring ambulation, which isn't necessarily reflective of how they like to exercise behavior.
So the one thing we are doing is that we have a machine that analyzes gait. And so we're playing with that machine. We're trying to get all the parameters. It's kind of a tricky thing because they videotape and you have to make sure you get just the pause and all of this. But we're starting to get that, so we're getting some good data. And I am very excited because I have talked to my PT colleagues, and I'm going to be working with Katie Rudolph in interpreting this data a little bit, because there's a whole loop. And being a sensory person, I tend to just focus on the sensory. But of course, how this all impacts motor is huge, and I think it's a good question and something we're going down. But ambulatory and then just in their home cage, we haven't done. Wow, so many. Okay, you and then you.
I'm the first you?
Yes, sorry, Dr. Willard.
Human joints, typically you're not innervated on the articular surface.
Correct.
To any extent, but I think there's evidence that if you get an OA joint in a human, you get part of the pain is that you innervate it. You start bringing the vascular buds that grow into it to try to replenish it, or carrying do you get to see the same thing with the rat? And could the exercise actually be preventing or slowing down the innervation?
Okay, so we've got AIM-1 and AIM-2. So this is exactly what I think is happening, at least with the neuropathy. So you get, definitely in the humans, you get the angiogenesis that you're talking about, the vascular, and you also get the innervation and the pathology. And so definitely within the synovium, the cartilage is gone, but it's definitely altering inside the subchondral bone and the bone itself. And so this definitely in the animal literature has been shown after complete Freund's adjuvant, which is more of an inflammatory arthritis than the MIA. So whether it occurs in the MIA model, I would bet money that it does, but it hasn't been shown yet. So yes, I want to do that, but we haven't yet. Scott?
Thanks, Tamara. I have a question regarding the voluntary versus forced exercise.
Mm-hmm.
And I can't help but wondering, in the forced exercise paradigm, are you getting an additional effect or benefit due to the stress of the situation? And makes me wonder, just people coming to therapy to exercise, is it stressful on some level?
Right.
But I mean, I'm just trying to understand what the differences might be there. So I didn't know if you had any thoughts or comments.
So that's a tricky question. So yes, I suspect that there is a stress component, but what exactly is happening there, I don't know, because we know that there are differences between acute stress and chronic stress. There's differences in mediators, there's rebound, there's alterations in everything from cortisol through the opioid system. And so how all of that is playing a role within the forced exercise, other than if I block the opioids, I get the pain back, I'm not sure. I think it's a great question. And I think it's a very valid one. That's one of the reasons I really wanted to go to voluntary. Ling, sorry, back to you.
That's all right. So it's also related to the comparison between voluntary exercise versus the forced. So I was just wondering, because the two exercise paradigm itself, one is on the flat surface running and the one is the wheel. So maybe that's affecting different joints, different muscles when they're running, but both are exercise, so actually affect their central, the supraspinal. So they're all getting this reward experiences. So your CPP would show the same thing, but not the weight bearing.
Oh, interesting. Yeah, that's definitely definitely true. Weight bearing, we think of it as like, online pain, but shifting weight away from a hind paw could reflect a learned response, or it could reflect some other impairment with the joint or the surrounding tissue. Now, we've looked at the bone, but there's a lot of other tissue there that could be examined, and we haven't really gone into that yet. And I think it's a great question. Something Dr. Rudolph keeps on hammering at me about. Oh.
So at the risk of embarrassing myself publicly, I was wondering if we could go back to one of your earlier slides where you showed the map across the United States, the populations of people who have OA.
Let me go and do, that's like the second slide, so I'm just going to cheat. There you go. Oop.
So, especially with the women, it looks like there's a high concentration of people experiencing it who live in states with high populations of poverty or food insecurity. So that gets me to think from the prevention side, and then you're looking next, so you said you're interested in moving forward with looking at the prevention side, how you would model the food insecurity and nutrition component that seems to be affecting the human population in the rat population, because I think it could have significant public health and socioeconomic benefits if we were able to put some science behind the rhetoric we usually hear.
So I think it's an excellent question, and so we've been focusing on the exercise component, but not so much the food intake component, aspects of nutrition. We haven't even really gone after the weight component, something that could also be very impactful and very interesting. One of the reasons why we really haven't done this in the animal models is that too many variables makes it so hard to move forward. But what I think would be very interesting is to get the latest maps and really overlap that with the obesity maps that are out there, with the sedentary and exercise maps that are out there, and I suspect that you're dead on. But and this is because it's more out of my realm, quite honestly, and I don't want to embarrass her, but Dr. Thompson might actually be able to correct me. But I'm not as sure that those maps are gender separated or sex separated. So the relative men to women rates of obesity at these different areas or sedentary, I don't know if they're out there. If they are, that would be extremely interesting, yes.
So Dr. King, those maps that the CDC has, the pretty pictures are typically not separated by men and women, but the data is in there. They go through all the demographics.
Okay.
And it's also diabetes. So obesity and diabetes really well reflects at least the map of the women data that you have here.
Yeah. Yeah. All right. I think I'd probably ought to stop the discussion. It's been fantastic. Thank you guys so much for playing.